Good afternoon. This is Kim McCleary. I'm President and CEO of the CFS Association of America. It's November 11th, and this is the 17th webinar in our 2010 series. It's my pleasure to be online with Dr. Lucinda Bateman from Salt Lake City, Utah, and so many of our members and supporters and listeners. We have about 320 people registered for today's program, and we're just going to wait a moment for many of you to join us as the queue opens, and then we'll get started. A special thank you to our servicemen and women on this Veterans Day. Thank you for your service to our nation. Okay, it looks like we've got a good bit of the audience with us, so we'll get started. Our topic today is Doc Talk, communicating with your healthcare team about CFS. And the frustrations in dealing with physicians and other medical professionals, I think, are more and more widespread in this time of managed care, but people with CFS have a particularly difficult time finding healthcare professionals who understand their illness and are willing to work with them and make the sort of trial and error approach to effective management that it often takes. And Dr. Bateman is here today to share some strategies for communicating and working as a partner with your healthcare professional to achieve these things. So before I make a formal introduction of her, I just wanted to go through some brief kind of housekeeping tips. We have about 65% of our audience today has been with us for an earlier webinar, at least one, and for many of you this is multiple frequent flyers of our webinar program, but just so the folks who are new understand that Dr. Bateman and I are in different locations. I'm here in Charlotte, North Carolina, and she's in Salt Lake City, and although we're all looking at the same screen and hopefully seeing the same things on our monitors, we can't see one another and we can't see you. So this is a bit of an unusual setup, but very efficient in terms of neither of us having to get on an airplane to go anywhere to offer the program to you. We do ask a few questions, as you know, in the registration process, and the questions try to be specific to the topic. And you let us know as you register that about 3/4 of you are currently experiencing frustration with your healthcare team. And more than that, almost everyone has experienced frustration in the past. So as I remarked to Cindy before we got started, at least that's moving in a positive direction, and perhaps after our discussion today, there'll be more success among the folks who get this information. The questions that you might have submitted with your registration were shared with Dr. Bateman in advance, and we'll cover some of those at the end of her presentation. If you have questions while she's speaking, please go ahead and type those into the little control panel. On the right side of your screen, there is a dialog box, and those questions will come into me. I will try to triage them as much as possible and hang on to the ones for Dr. Bateman that will cover as many as we can at the end of the program. We are recording this session, and the recording and the slides will be posted online within a day or two. We put the recordings up on our YouTube site. We find that's the easiest format for people to access, and we'll send you an email with the URL for the recording and the slides once those are available. And just as a reminder, although Dr. Bateman is a physician, this format really does not allow us to address individuals' questions about symptoms, test results, therapy, diagnostics, medication levels, or any issues of a personal nature. So please refrain from sending those types of questions in, because we just won't get to them in this format. So without further delay, it's really my privilege to introduce our guest today. Cindy and I met many years ago in Salt Lake City. She has had a strong interest in this condition as the result of her sister's illness, and unfortunately her sister passed away a few years ago, but as a tribute to her sister's experience and suffering with CFS, Cindy has really made it her life's work to help people with CFS and fibromyalgia. She is, as I said, a physician and specializes in internal medicine, but at this point works in a solo clinic called the Fatigue Consultation Clinic, where she sees predominantly CFS and fibromyalgia patients. She's also been an important clinical collaborator for many studies, including some of the ones that the association has funded. We're currently supporting a project at the University of Utah that's led by Kathy and Alan Light. And Dr. Bateman has been the clinical collaborator in providing the patients and controls for that study. She's also involved with some studies that Ela Singh is doing at University of Utah, and she's participated in several pharmaceutical companies' studies of various therapies for CFS and fibromyalgia. In addition to her work as a clinician, she founded the Organization for Fatigue and Fibromyalgia Education Research, better known as OFFER, and that organization has just done a tremendous job in the Salt Lake City area, educating both patients and the general public as well as healthcare professionals. And it's just always so impressive when I've been at Cindy's conferences to see the crowds that gather from really all over the western states to attend her programs, and the engagement that she has with local healthcare professionals that cross a lot of different disciplines and specialty areas. Cindy is also a former member of the association's board of directors, and she formerly served on the Department of Health and Human Services CFS Advisory Committee. So I think she is rather unique in all the world in her commitment and demonstration of that commitment through her many professional and personal contributions to the field and to patient care. And we're delighted to have you with us today. Thanks, Cindy.
Thank you.
Okay.
Glad to be here.
I'm going to pass the controls over to you, and hopefully this will work as well as it did a little while ago when we practiced. The audience will see some switching of the slides, and then you can go ahead and get started. And I'm going to mute myself so I don't interfere.
Okay, so I'm assuming you can see my screen now, and if that's not the case, please let me know.
Yep, you're up.
Okay. Well, it's great to be here to talk to you about Doc Talk, or communicating with your healthcare team about chronic fatigue syndrome. You know, I realize that this is a huge issue. This is a tremendous challenge that you as patients face, to try to find healthcare providers that can treat you compassionately and understand about your symptoms. I know how frustrating it is. The most common request we get at our nonprofit when patients call is, how can I find a doctor? And I'm sure that's true with most nonprofits. And you know, to be honest, I'm not sure what to tell them, except for maybe the very thing that I'm going to provide for you today is what I would try to tell patients when they say, how can I find a doctor who could take care of me? You know, our system is not well suited to taking care of an ill-defined chronic illness. I mean, it's kind of a broken system for everybody who can't have their problem taken care of in a few minutes. So you're not alone in that. And the other problem, besides our medical system right now, which is really trying to be more efficient and more standardized, which isn't always good for us, is that we know that knowledge about CFS is very slim among physicians. They're just not trained about CFS, and they're not always, they don't always know how to access information, and those create biases and problems. So given that, I just want to give that background that I really understand we have a challenge. I'd like to talk to you about, you know, ways we might be able to solve this problem. Kim, I am trying to figure out how to advance my slides.
If you click, just click your arrow on the screen, and it should give you the opportunity then to forward your slides, advance through either button.
There we go. There we go. Okay. Yeah, it's a little tiny, barely can see it, arrow down there at the bottom. So on this slide, I just wanted to recognize that there are lots of medical providers that you may engage with as you're trying to improve your health. Physical rehab providers who are going to help you with movement or areas of pain or other kinds of rehab. Certainly mental health providers to help you learn to deal with chronic illness issues and how to deal with grief issues. Alternative and complementary medicine. And I hope you take advantage of all these providers, but I do want to say that my message today is going to be specifically about medical providers. And some of what we talk about can apply more broadly, but it's really, I think, the worst biases and the most misconception probably exists in the medical provider realm. So I want to talk about really how you can make the most of your medical appointments by learning how to make the system work better for you. And it's going to be complemented by some advice about how to take good care of yourself, because the system, if it's not going to meet up to your needs, you're going to have to fill in the balance with what you do to take care of yourself. And that's going to be a recurring theme through our slides today. Definitely, first and foremost is to find a good primary care provider. I have every patient in my clinic, they are required to have a primary care provider. And you need someone like a primary care provider. You know, it's nice if they know about CFS and have skills in CFS, but it's really not mandatory. They just need to be personable, open-minded, accessible, and up-to-date. You need to be able to have a conversation with them. You need to be able to get in to see them, and they need to be open-minded and up-to-date enough that they can learn new things if you have a chance to share that with them. So some examples, just so we're all on the same page, of primary care physicians. This might be a general internist like me, a family practice doctor, a pediatrician for younger people, nurse practitioners. They have several kinds of initials to identify them. Physician assistants. These are all trained to provide primary care. And to be honest, I have a nurse practitioner and a physician assistant in my office who I think offer at times better care than many doctors I know. And sometimes there's a bit of a harsh judgment about them not being a doctor, but if they do their job and they're well prepared, they can be excellent support. So, and whoever your primary care provider is, they need to coordinate health care. You need to coordinate your health care, be responsible for the umbrella that protects you, and they should pay attention to these things. And I want you to judge your primary care doctor by whether they're doing these things for you. One is they should focus on helping you with preventive tests like mammograms and colonoscopies and talking to you about your cholesterol and blood pressure and those kind of things. They need to provide a source of urgent care, so you need to be able to talk to them about things that come up. I mean, if it's super urgent, you might have to go to the emergency room, but they need to be relatively accessible or have a team of people that you can get into if something changes urgently. It's really their duty to initiate and follow the evaluation of almost any problem, even if you're sent to a specialist. So they are the ones who should kind of pay attention to what's going on with you and bring it back to the home medical clinic where they can coordinate what's going on with you. And a good primary care provider needs to be willing to work on any chronic symptom or condition indefinitely. They may want input from a specialist, but once your condition is stabilized, they should be able to provide some oversight of management or elements of management. And they might need to help you be referred to a specialist if you need to go see someone. Now, specialists are, I wanted to say one more thing about primary care docs, and that is they make a lot less money than specialists, people who do a lot of procedural work. And so there are many pressures that force them to be more efficient and to take less time, which we're going to talk about. Many pressures upon them to continue to be productive. But I do find that primary care doctors are more open to ideas. They tend to be a little more altruistic, and they're the ones who will try to take care of the whole person in the context of your family and everything that's going on in your life. Now, the flip side of this is a specialist, and specialists have a narrow niche. They rule out, they identify and treat a problem in their specialty. They need to stay very focused, and you need to stay focused with them. You know, it's helpful but not imperative, or likely for that matter, that they know about CFS or fibro and how those illnesses might change the presentation of the specialty illness, or change how you respond to treatment, how the illness might change how you respond to treatment. So you might need to do some homework on your own. Let me give you an example. Actually, gastroenterologists are pretty good at understanding about irritable bowel syndrome, but you need to go to a gastroenterologist to make sure you don't have colon cancer or ischemic colitis or an inflammatory bowel disease, but it's very likely that your illness will contribute to irritable bowel syndrome, and it's important that both you and that specialist understand that. What about cardiology? You know, they're looking for someone with valve disease or coronary disease or some blatantly dangerous problem with the heart, but people with CFS might have orthostatic intolerance, palpitations, and chest pain, and that might be where the problem comes is they may not pay very much attention to the symptoms that come from having CFS that relate to their field. They may or may not be insightful about how your disease changes the presentation of illness in their specialty. So that's why you need to do some homework on your own about how CFS symptoms fall across many systems in your body and how it might affect how a specialist views you. Another example of them is an orthopedist. I had an orthopedist come to one of my talks on fibromyalgia, and I thought that was tremendous because he realized after many years, and this was an older orthopedist, that fibromyalgia changed the way his patients presented. And it's different to just have hip arthritis than it is to have hip arthritis combined with fibromyalgia. So the pain might not go away in the same way as just replacing the joint and having the pain all go away. So it's important to understand that these specialists, our expectations of them, we have to be kind of narrow for a while until their knowledge grows. So go to them, get what you need from them in their specialty, but stay focused, and you might want to come prepared to know how your illness might impact the symptoms in that area. So let me tell you about concerns that have been expressed to me by medical providers about treating CFS and fibro patients. In the last 2 or 3 years, in the context of speaking about fibromyalgia drugs, the drugs that have been FDA approved for fibromyalgia, I have probably spoken to 300, 400, 500 primary care providers and other specialists about fibromyalgia. So there are a lot of parallels, right? And then often, if possible, our conversation will turn to chronic fatigue syndrome. But they very routinely, and you get this feeling from them, so this is nothing new. They say that patients with CFS are time-consuming, and it reduces their reimbursement and clogs up the schedule, and someone's going to have this long list of 1 million complaints, and it's not just that it's time-consuming for them, but it's a bit overwhelming, to be honest, to primary care doctors, because it seems so complicated and they don't know really where to start. You think it's overwhelming to you, it's like actually overwhelming to your primary care physician too. Also, I've heard people say, these patients never get better. Now that's one thing. They've also said, a few people have said they don't want to get better. And I totally disagree with that. Of course it's not true. And the never get better statement may really reflect a lack of knowledge about chronic fatigue syndrome and fibromyalgia, about the chronic nature. And that's something they can learn together with you. And the last thing, of course, is just lack of knowledge and information. They're really not sure how to diagnose it, and certainly they're very uncertain about how to treat chronic fatigue syndrome. So these are some barriers. I just put this up here so that you can think about what might be going on that is compounding your visit. And doctors are pressured to be efficient by their employers. They have quotas, how many patients they have to see in a day. I know doctors that lose their jobs if they don't keep up a certain pace in the clinic. So these are real important barriers that interfere with your relationship and with the quality of your visit with your physicians. So we really need to make the system work The system is very inflexible. We've got to make the system work for you, and you've got to understand it a little bit and know how to use it. So how can we make the system work? We're going to talk about some ways in the following slides. The first thing I want to talk about is how you can help economize time and improve communication in the visit. You need to be prepared and organized and be respectful of time limitations and prioritize your issues. It's just a reality that we have to face when you go see the doctor. So what are some ways you can make your time count? First, and I really emphasize this with my patients, schedule your appointments in advance so you're sure you can get in. Don't wait until you're having a problem or until you think of going to see the doctor. Avoid crisis management. Schedule regular appointments. Make sure, to the degree that you can ask for this, that the appointments are long enough. Now, there is a way that doctors get paid a little more for longer appointments. So if you have a discussion with your physician or with the schedulers, see if you can schedule appointments that are appropriately long for the amount of things that you want to discuss. Next, arrive early, or at least be on time to your appointments. I know it's hard, you don't feel good, sometimes you get lost, the parking's difficult, it's hard to walk in, but plan ahead, because if you arrive late, you've already compromised some of your time with your doctor, and the doctor's frustrated. It's okay if you arrive a little early, because you can relax in the waiting room and kind of let your blood pressure come down, think about what you want to talk about, and kind of be prepared to go into the visit. So rather than being flustered and frustrated and running in late. Even in my clinic, we schedule 30-minute visits, and I really encourage people to be on time, because I devote that time, and if they arrive 15 minutes late, it really compromises our ability to have a quality visit, and they come in all wound up and upset. The third thing on this page is to be strategic about the appointment time of day. Now, you may or may not have control over this. It depends on how far in advance you schedule your appointment. But if you schedule the first morning or the first afternoon appointment, you're going to get a provider that's less tired and backed up. Now, they may be worried that you're going to back up the rest of their schedule, so you still need to stay on time. And the other advantageous thing is to have the last appointment of the day. You might have to wait, or the doctor might be behind, but there's no one waiting. And you can sometimes get your time in if you schedule the last appointment of the day. What are some other ways you can make time count? Now, this is pretty important. A physician needs to know how to pace the visit, know how to spread things out through the time to get the things done that you need. So it's important that you state all of your concerns and needs clearly at the beginning of the visit. So, the first thing you need to say, I need to talk about my sleep, and I also need some refills, so that the doctor can think about what it is you want to do. I'll tell you, there's nothing that comes up my schedule more than someone who we've spent 29 of the 30 minutes, and then they say, oh, I have one more thing. I've been having this pain in my chest. And all of a sudden, this opens up a huge diagnostic question, and I should have spent the whole 30 minutes talking about that. So try to have a little list and let them know right at the beginning what you want to cover, so that they know what to expect. You also need to prioritize your concerns and address only the most important current treatable issues. So, people with CFS and fibro have a large number of symptoms going on, pain and fatigue and immune dysfunction and cognition, and there's so many aspects and all the comorbidities. But remember that you have a chronic condition, and you cannot put it all on the plate every time you walk in to the doctor. There's never going to be enough time. So you want to prioritize what things are at that moment the most distressing for you, and also something that is treatable. People with chronic fatigue have chronic fatigue, so if your fatigue is changed or worsened, it might be an important issue that comes to the top, but maybe it isn't the most important thing to lay out every time you come in, except to remind the doctor. So you need to let the doctor know what are 1 or 2 things that are most important for you to discuss in that visit, and then take one step at a time and try to have realistic expectations about what actually can be changed, because there are lots of things about your condition that you've lived with for 10, 15 years. It's unlikely that the expectation is really unrealistic that your doctor's going to be able to fix all those things. And even if you don't have that expectation, sometimes they think you do. So you need to express to your physician how to prioritize, what's important to you, and try to keep it simple each visit. I think it's helpful to bring written information to convey your concerns clearly, but it needs to be very concise, not long. I asked a patient to go home and keep a record of something. I can't remember what we were talking about, pain or sleep. And when she came back, she'd worked so hard. She brought like a 30-page handwritten journal and handed it to me. And there was just no way I could pick out of this journal and this narrative in the short time that we had the information I needed. I needed a little list or some variables or 10 blood pressure measurements or something very concise that would convey to me efficiently the information. All right, what else? How else can we make time count? Well, prescription refills are one way that time gets eaten up in a visit. So the more organized you are about your refills, that's whether you're in person or by phone, it will help minimize errors and reduce the number of interactions. So I really like it if my patients either indicate on their list or write a list of medicines that need to be refilled and kind of, again, notify your clinician up front that that's going to be an issue, and they can choose whether they want to do it in the visit or delegate it to someone. And be sure that you include the correct drug name, the spelling, the milligrams of the pill, how often you take it, whether it's a 30-day or a 90-day supply, and how many refills you want, because I don't know how many times someone will call the office and say, refill my trazodone. And we've made dose changes, and I don't always remember which prescription plan they're using, and it just takes a little bit more work. So the more you can supply that information very efficiently, the more people will be happy with you, and they won't feel like you're a drain on their time. All right, how about forms and letters? This is my own policy, so you're going to have to decide how you work these things out with your individual providers and have a discussion with them that's open. But I tell my patients I want them to fill out forms in advance as much as they can. So if someone's got a disability form, or they have to have something for school, or their work as FMLA papers or something like that, I usually have my patients fill in, have a copy that's blank, and fill out another form in advance with things like your name and your phone number and your address. Don't make your doctor write those things in, and be sure you fill out the part that you're supposed to fill out. It's really nice if you fill out the doctor's name and address and all those things and your insurance and anything that you can do. I usually have people write down about their symptoms, and those disability forms ask for the day you first became disabled and things like that, and I always have to dig back through the chart and try to remember. So the more you can fill it out, the better. Just don't dump paperwork on your doctor. Remember that I call it homework in my office, is the only thing your physician gets paid for is a face-to-face visit. They can't get paid for a phone call, for emails, for filling out forms. So all of that extra paperwork just adds a burden and lengthens their already long day, and it creates sort of a bad feeling, right, that you don't want to have with your doctor. You want your doctor to feel like you're trying to make their job easier. And you can do that by filling out the forms and making it easier. Same with letters. When someone requests a letter, I need a letter to my principal at my school, or I need a letter to my boss. When you ask for a letter, sometimes it's tempting to just put the work on the doctor, but it's as hard for the doctor to write the letter as it is for you to write the letter. In fact, it's sometimes worse because we don't know exactly what the letter needs to say. So if you can make a mock copy of the letter, make sure you put the heading, who it goes to, what the address is, and your doctor doesn't look up the name of the school and the principal and all that stuff, and then just draft the letter like it's the doctor talking and make it really short and simple. just to the point, because that's one thing that's different about a doctor than a patient writing a letter. Anyway, and I usually just say this is a model of the letter. You can edit it or you can write your own letter, but here's what the letter needs to know. That's what I say to the patients, and it has made making letters so simple. People will email, copy the letter, we'll put it on Word, edit it just a little bit, and it makes it so easy to provide letters for patients. And it's always nice if you provide a pre-addressed stamped envelope as well. And you know, you really need to know your insurance, so I'm not going to say too much about this, but know who your approved providers and labs and hospitals are. You know how to utilize your prescription plans. If you don't have insurance or no secondary insurance, or if you have high deductibles or you have high co-pays on your medicines, just talk to your doctor about it frequently. Don't assume they remember, because there's a big variety. I mean, I just really would appreciate it if patients remind me, doctor, I'm going to have to pay, I'm in the donut hole, or I'm going to have to pay cash for this, because I can't keep track of those things. And I can make better decisions if my patient is very knowledgeable about their medications. Okay, so that's a little bit about saving time and with your physician. What do we do about the million complaints, all these multiple systems that are involved? Well, we can all do better about communication. Again, prioritize your issues. Don't spread them all out on the table, everything that's always there. I'll try to talk about the things that are most important that visit. And you really need to know about your medical issues. You need to be well informed about your own medical conditions, and the better you're informed, the better it will help your whole case go forward. Develop good communication with your providers. Work on that. That should be the focus of what you do. If you don't efficiently give them good information, they may not be very good at helping you. That's the bottom line. So, and I'll tell you, there are barriers, right? If the doctor's in a hurry, if they're holding the doorknob, if they're tapping their toes, you can see that the communication is going to be more challenging. So the symptoms of chronic fatigue syndrome are particularly difficult to communicate. It's hard to describe what fatigue feels like. It's hard to describe pain. It's hard to describe brain fog. So each one of the major symptoms of illness is time-consuming just to communicate what it feels like. So what I'm showing you here is an example of a technique we've used in our own office. This is from my office. This is a de-identified but a real patient's form. So every time someone comes in the office, I have them rank common symptoms. So you can see that then they just sort of rank a range, because it's not perfect, but you can see this person has fatigue and they're just kind of down in the dumps, and brain fog, but their pain issues are the highest, and they do have headaches are not so bad right now, and they can't sleep, and they're moderately active. And then I write that we can talk about 3 things in that visit, 1, 2, and 3. You can see this guy's written in 4. That's okay. And then I have patients fill out a pain diagram, because if a person can draw their pain, I can see immediately. It doesn't take much discussion to understand about the pain. And it takes a little more discussion to clarify and talk about it. So you might want to devise some kind of a simple tool that can communicate your symptoms to your physician over time. Now this is a little closer up view and a little more simplified. You can see on this one I have kind of 3 measures of fatigue and brain activity, and I have 3 measures of pain issues. But you don't have to have one that complicated. You can just talk about the main issues, and this is a very quick way to convey to your doctor what are the most important symptoms affecting you right now. And here's an example of one that's filled out from a sample patient whose fatigue on that visit was very high, and there's a little clue maybe about why their fatigue is worse than usual, and the pain issues are not so bad that day, and mood's really not an issue from the patient's assessment. That communicates something really quickly to the physician about how you view your symptoms and how you prioritize your symptoms. Now I'm going to show you a few pain diagrams that are just cartoons that I did in the paint feature of my computer, but a physician can recognize certain illnesses simply by the distribution of pain. And you may say, oh, I hurt all over, and your joints hurt all over. Or you might say, oh, I hurt all over, and it's really the major muscle groups in your body. Or you may say, oh, I hurt all over, and to your doctor, he will or she will recognize that you have a peripheral neuropathy. Or you might color in a pain diagram like a fibromyalgia patient that really every major area that can hurt seems to hurt. TMJ and headaches and neck, shoulder and chest pain and abdominal pain and muscles and all those things. But your pain diagram can change from week to week and help your clinicians understand what your most prominent areas are, so they can help you in a diagnostic process to try to decide if they should be doing some other kind of workup. Plus it just saves a lot of discussion. I think it's very educational. You know, I have shown pain diagrams to doctors and they just look at it and go, wow, because they don't really understand how widespread and how debilitating the pain can be for patients without some kind of quick way of communicating it. Okay, so you know, your CFS and fibro or whatever your symptoms are very important, and they're important to you, but it's also very important that you understand everything that's going on with your health and engage your provider and tease apart how symptoms might have a contribution from different conditions. So the two of you as a team can systematically identify and treat all relevant medical and mental health conditions. And you know, I put mental health conditions up there because you know there are times when you just get overwhelmed and discouraged, and the more you know and have a relationship with your primary care physicians, the less likely they are to just pass you off as, oh, just depressed. I have a very open communication with my patients about when they have contribution from anxiety or depression or discouragement or when they're overwhelmed, because they know I understand their illness. So it's fine to talk about those things because they know I don't disregard their CFS and fibro, and it gives us a safe forum in which we can talk about what's going on with their emotions. And as you work with your providers, you can develop that kind of a relationship. So you want to show your primary care provider and all your other doctors that you are mindful of your health by keeping track of your own basic health prevention. These are things that have been proven in studies to prevent disease down the road. And that would include, you know, having a physical, a pap smear, a breast or prostate exam, getting your mammograms, being immunized appropriately depending on your decisions about whether you're going to do that, following your cholesterol and blood pressure, colon disease, and monitoring drugs that you're taking with certain kinds of lab tests, like if you're on something for cholesterol, making sure it's not affecting your liver, or if you're on you know, thyroid, to make sure that you are monitoring that. So you can keep track of that. Don't wait for your primary care physician to go, oh my gosh, you know, are you doing this? You should keep a record and say, doctor, I had my mammogram, you know, a year ago. It's time for me to have another one now. Can you help me? Or you can actually sign up for your own mammograms, but you know, be a friendly reminder to your overwhelmed and overworked provider. Help them keep track of all your basic health prevention. And if you're not sure what those are, most of them are on this page right here, but you can have a visit with your doctor. Say, what are all the preventive things I should be doing with my age and with my certain things, and I'll help you keep track of them. You want to know your medical conditions very well. And you should have your own, what we call a problem list. Doctors know what a problem list is. It's a list of your major chronic issues that have to be tracked. So that might be hypothyroidism or osteoarthritis or high cholesterol. These are things other than your CFS or fibromyalgia, sleep apnea. But you should track them. Don't just leave them for your doctor to manage. You should know when your last lab test was done and that your medication dose is right and how often you should be getting another screening test. And if you have arthritis, you should know that it should be if it's been assessed and how severe it is and what the plan is and what you treat it with. Do you see what I mean? So you want to be very proactive about tracking your own issues, not just the preventive ones, but everything that relates to your own comorbid medical conditions. Don't let them fall by the wayside. And you want to show your doctor that you're motivated and tending them. Now this may be a little sensitive issue, but your doctor needs to know that you want to be well. Do you remember that I said that doctors say patients they don't want to be well? Well, of course that's not true, but these are some common things that happen with my own patients sometimes that make me wonder, do they want to get well? Of course I know they're overwhelmed and they're tired and they're sick and they can't get places, so I get it. But a primary care doctor out in the field who doesn't have a thorough understanding of CFS, they might not understand these issues. And let me give you some examples. One is try medications as suggested. So if the doctor says, let's try this medicine, go home, try it, you should do it. If you agree to do it in the office and you're on board with it, don't come back in a month and say, oh, I forgot. Or, oh, I talked to the pharmacist and I decided not to do it. Try to show an effort to be a team with your doctor. Because if he or she suggests something and you just throw it away, they may interpret that as being as you not really wanting to work with them or get better. These are some other examples. If you've got sleep apnea, do your best to try the CPAP and try the treatment first. Don't come back and say, oh, I can't possibly try that. You need to show them that you've made your best effort. If after your best effort you can't handle it, and you both understand that and everybody's given it their best try, that's one thing. But don't be afraid to try to implement treatments. This is a common one, are blood pressures and blood sugar measurements. So I send someone home, I say, I want you to bring back 10 blood pressure measurements, or I want you to bring me back daily blood sugar measurements, and they come back a month later and they just either haven't done it, or the most common one is this, oh, I left my list at home. So that does not show that you are engaged and that you want that comorbid condition to be managed as best possible, because those comorbid conditions definitely affect your general well-being, and they will pull down your health and they will make your CFS symptoms worse. Now another one is getting your blood drawn. I don't know how many times I've sent people away with a prescription to get their blood drawn so I can screen for important issues. I wouldn't order a blood test if I didn't have a reason to do it. And it'll be a month or 2 months or 3 months will go by, and sometimes patients will just hurry and get it drawn, or they come back to an appointment without ever having done it. And I feel sometimes in that setting, even though I know why it happens, I wonder, that are they too depressed to act on this, or do they not understand that this impacts their general health? So try to follow through the best you can and then tell the truth. So if you fess up, if you didn't do it, just say you didn't do it, or if you did, if there were reasons why you couldn't do it, talk about it. I had a patient the other day say that they changed their thyroid medicine the way they suggested, and they said, well, I'm not going to tell my primary care because I don't dare tell him that I'm on a different dose. And I said, don't do that, because the doctor's going to draw your blood and he's going to think you're on the other dose and give you bad advice about how to change your medication strength. So try to be very honest and straightforward. Don't be afraid to stand up for yourself and try to do the best you can. Okay, so what about the real illness that we're most concerned about? This is where it gets more difficult, of course, but you should help your provider become familiar with the way we define each of these illnesses, because I don't think that physicians necessarily know that. I mean, I have spoken to, as I said, hundreds of physicians who really don't understand how to make a diagnosis of fibromyalgia, for example, which is much more common, much less debilitating in a certain set of patients. And I teach them the very simple ACR criteria for diagnosing fibromyalgia syndrome, which is, and I didn't put the time limits on these diagnoses here. I was really just doing it as an example, but at least 3 months of symptoms, widespread pain, 4 quadrants of the body, and tender points. That's how they need to make a diagnosis of fibromyalgia syndrome. And there are ways to convey to your doctor how scientists and clinicians and specialists in the area diagnose CFS. I think one of the best ways is to give them a copy of the scientific paper that establish the definition. But sometimes a busy doctor is going to just look at a 10-page journal article and they're just not going to get to it. So if you can find a one-page summary or a very concise summary of the way the diagnosis is made and the typical symptoms that are required to make the diagnosis, that might be helpful. They might like to know that CFS is characterized by post-exertional malaise and the fatigue and headaches and flu-like symptoms and sleep and infection and cognitive limitations and autonomic nervous system dysregulation. So you can see if you can provide a one-page definition to them and they can put it in your chart, it will help them while they're trying to take care of you. Whatever resource information you provide, you should keep it simple. Make sure it's a high-quality resource, like a journal article, something from a major academic website. And you need to respect your provider's knowledge and judgment, but you can respect your own as well. You may know much more about your illness than they do, and if you don't, you should. You should learn everything you can from very good sources, and then do the best you can to provide them resources. Don't assume that they're going to go do a lot of background research on their own. It would be great if they did. And remember that they're very, very knowledgeable about many things in medicine. So they should be able to give you a lot of good advice even if they're not an expert in CFS. You can teach them about CFS through their experience with you. And sometimes I'll help turn a bad experience around for patients. So they'll come back, they said, you know, I saw this specialist and oh my gosh, it was so hard because, you know, they rolled their eyes and they didn't know about CFS. But every interaction you have with a physician or another medical provider, if you can be genuine and communicative, you can be responsible for teaching them about CFS through their experience with you. So you become part of the effort to raise awareness. So if you can kind of look at it that way, it won't feel so kind of horrible when you go and people don't know about CFS. You can teach them. And the interaction with your primary care provider is an ongoing one. When you share your experiences with them about how you try to exercise or about how you try a medicine and what happens, as you share your experience with them, they learn about CFS. It's very important. Okay, what else is important? You need to know your medications very well and take responsibility for them. Do not be naive and clueless about your drugs. You should know the names, the size of your pills, how many times you take it. You should know why you're taking it and what it does. You should know a little bit about the side effects without getting totally, you know, overly concerned. You should discuss side effects, but put them in context with the experts that are helping you know about side effects. And you should carry an up-to-date list, and you should give it to every medical provider that you visit. Everyone should know all the medications that you're taking. I won't even start the visit with my patients until they have completely written down all their medications. Now you can list your medications how you want, alphabetically. In this particular slide, the generics don't start with a capital and the trade names start with a capital. That's just a little code I have for myself about whether a generic or a trade name. But really, this is the kind of med list I'd like to see, is a med list that shows your insight and organizes your meds. It doesn't look like such a long list. If you can divide the list in the specific areas about why you take the medicines, it helps you understand your medicine. So if you've got allergies, you might be on an antihistamine and an inhaler, and then some of the medicines you take as needed. That's what PRN means. And it's kind of nice to convey to your doctor how often you actually do something. So for pain, this person's on an anti-inflammatory and they're on an opioid medicine that they take as needed, but then they give me a piece of information that's very helpful, right? That they might take 8 tablets a week, not 8 tablets a day. And some people fudge on this, but I think it's very important to be very accurate about how you take your medicines. These medicines are for sleep, and then the Cymbalta, course, might either help depression or the pain of fibromyalgia. So if you can keep a list of your medicines that teaches your providers about you know, why you're taking them and helps you understand why you're taking them, you're a lot less likely to have errors. And not only that, your doctor's going to be, and your medical providers are going to be very impressed with your initiative and how much you're trying to take care of yourself. Just a few things I'd like to say about medications and about adding medications. Sometimes patients are desperate and add too many medications, but sometimes doctors are desperate and they just keep piling them on, or you go to multiple specialists.
Hi all, it sounds like we have lost Dr. Bateman. I'm trying to get her back, but if everybody can just hold for a moment, we'll see what happened on her end. So if everybody will just bear with us for a moment, please.
Are you there now?
You're back. Cindy, we lost you.
How long ago?
Probably 3 or 4 minutes.
One slide?
Yeah, you were on the general suggestions about adding medications slide, and you just started. You said, I want to make some comments here about adding medications, and then we lost you.
You know, I have no idea, but the mute button got pushed, and I may have. I don't think I pushed it, but I'll put it in view, okay?
Okay.
So we don't need to go through this slide too much longer, but, you know, really be sparing with your medicines. Take responsibility for them, assess the benefits carefully, reduce the doses when you can, talk with your doctor, because sometimes too many providers pile on the medications and no one's tending them. So don't just give that responsibility over to discuss it with them and make sure that someone's running the show, and that really is you actually, and then that you have some guidance about how you use those medications. Okay. I wanted to say, I just wrote a little note in the margin, and I'm going to come back to that. It's just saying that taking too many medications or being over-medicated or not paying attention may look like you don't want to get well. Remember I said that those doctors said these patients don't seem to want to get well. So taking initiative with your medicines to trim them and take them responsibly and really understand them shows that you want to get well and that you're taking responsibility. Okay, so how do we establish, you need to establish treatment and management goals with your primary care physician. Have reasonable expectations about what you can do and what you can't do. You've got a horrible chronic illness, and even a CFS specialist is not going to magically cure your illness, right? So if you go into your primary care and they think that you want to be fixed or cured or you want everything to go away, they're going to be overwhelmed. So you need to be clear about what you want them to do. And that, I think that reasonable goals are to maximally manage all your underlying conditions and the major limiting symptoms of CFS. That's going to be your partnership goal together. And, you know, I've had a few patients come in, let me just go back here, And I go over their pain diagram and their symptoms and their meds, and I'm just thinking, oh my gosh, I don't know what to do next to help this person. I'm feeling a little overwhelmed. And I say, so tell me how you're doing. Do you want me to change anything? And they say, no, I'm doing great. I like my medicines. You know, I'm functioning pretty well. So that's where we need to be clear in communication about what you want the physician to do. And that's when I'm a CFS specialist, so imagine what it's like for someone who's in primary care. So you're going to gradually address and stabilize everything that's yours with your doctor. You know what's good about this? Your primary care doctor knows how to address all these things. They may overlap a lot with your CFS and fibro and even be part of it, but they don't have to know about CFS to treat asthma or treat allergies or treat irritable bowel or work on your migraines or even read a little bit about orthostatic intolerance. So if you can tease apart the parts and give them to your primary care in the language they understand, they can actually do a lot to help manage your illness. And this is the first thing I tell primary care doctors when I speak to them is dive in and treat all the comorbidities you can because you're going to help your patient tremendously. Okay, now this is a really important slide. This is pearl number 2 I tell primary care physicians, and that is you've got to understand that pacing is probably the #1 intervention for managing CFS symptoms. Now you need to learn about pacing. You need to observe cause and effect. What I mean by that is you need to notice that when you overdo, it creates payback. And you need to recognize your own symptoms, learn how to recover, because if you don't get it, you're not going to be able to convey it to your physician. It's super important. I think it's the most important management tool for CFS there is. And you kind of learn about it by the school of hard knocks the longer you're sick, that pacing can control the severity of your symptoms. The next step is to try to teach your primary care provider about post-exertional malaise. And you need to just give them specific examples. Doctor, I'm usually doing this and this and this, but when I go shopping with my family in the grocery store, if I stay more than 15 minutes or I don't use the wheelchair, here is the consequence. You know, and you say specifically what the symptoms are and how long they affect you, because it's stunning, actually. Even in my own practice, there's not really a good way to understand about post-exertional malaise without asking about it and asking for specific examples. And it's a way I gauge how my patients are doing, how severe their post-exertional malaise is, how low that threshold is before they have symptoms. Be patient, because this is not a concept that's well understood by the medical profession. So over time, sharing information, you need to teach your provider about post-exertional malaise and how pacing, how limiting your activity or doling out your activity and allowing recovery time is going to help you. Now this is another tool I use. This is step 3 when I talk to primary care physicians. The first is treating comorbidities, the second is pacing, and the third is your primary care providers can address these major supportive symptoms of your illness. And that is helping you work on sleep, helping you control severe pain, helping you work on how to find some kind of way to manage orthostatic intolerance and deconditioning, whether it's yoga or whatever's appropriate for you, and you need to teach them about your limitations. And of course, they can provide supportive care for you if you need it in terms of mental health. And these are things they can, you know, bite their teeth into, and I call these the 4 legs of the table because they're so important, particularly for managing pain and fatigue and keeping you know, if the pain is severe, it destroys sleep and it makes you depressed. And if you're depressed and stressed, you don't sleep and the pain gets worse. Anyway, so this is a really important paradigm, and they don't have to know about all the research or the the newest science of CFS to be able to provide this kind of support. You should think about it yourself, about how you're doing in each of these areas. Then, you know, you need to do things yourself that will help keep you healthy. This shows your motivation, but it's also going to make your health better. And if you smoke, you ought to try to stop. If you drink too much alcohol, you should be aware of how it destroys your health, and try to follow a good diet and work toward a normal body weight, and develop an appropriate, tolerable program of movement that's going to help you not get too physically conditioned. And these actions show your providers that you are motivated to get well. Plus, of course, it's going to help you, right? Be more healthy. So realistic goals are chronic for chronic maintenance and hopefully resolution are really to reduce symptoms to a tolerable place, to stabilize your condition, and to maximize your function. And if you can communicate, really have these expectations yourself and communicate that to your providers so they know that you're not expecting them to cure you. We don't really have a cure. I can't cure people. These are my goals when people come to see me in my clinic, is to get symptoms more manageable, to stabilize so that they're not, big push, crash, and up and down, try to get a more stable state, and to hopefully increase function as much as possible, sometimes with supports and other things besides just improving fitness. So if you can track and report your progress, that's going to be helpful to your medical providers. You need to let them know what you're doing, right? So find simple ways to track your symptoms and bring them to the visit. Report what is working. Give your provider a pat on the back. Thank you so much for helping me with my headaches. That medication is working so well. I really appreciate your input on that. That part is now so much better. So give positive feedback. Don't just talk about the negative things. Your doctor needs that just like everybody does, right? They need a pat on the back and to be told that some of what they're doing is great. Tell them what you're doing right. Tell them that you're going to an arthritis yoga class, or I have a patient who calls it house laps. The most exercise she could do is walking around her house. So she counts the laps or does it by minutes. Teach them about how you've learned about pacing, or that you've reduced your caffeine, or that you're working on sleep hygiene. Report to them what you're doing right and how it helps you, because that helps them see how motivated you are, but it also teaches them about the illness. Long-term, really, the reasonable goals are that major medical interventions are minimal, effective, and well tolerated. We want to simplify and just have you on exactly what you need, no more, no less. And you want to become self-reliant. You want your doctors to be your partner, but when you're really sick and in the beginning you want to lean on them a lot, but over time you want to kind of pull away and manage your own symptoms and be as self-reliant as you can, utilizing preventive and healthy behaviors and knowing about your medicines, etc., so that you can resume focus on the rest of your life and not have the illness become you. So just to go back in summary about these concerns expressed by providers about treating patients, saying that you're time-consuming and reduce reimbursement, there really are ways to help your provider by utilizing time wisely and efficiently. And just be mindful about helping your doctors get paid for what they do. They will appreciate that, and you'll have a stronger relationship with them. What about the million complaints that seem overwhelming and complicated? The better you communicate, the better you understand what's kind of a chronic problem and what's something new or something that's out of balance, and prioritize those with your providers. That's going to help. Teasing apart what's comorbid condition behind what's your primary illness, and taking initiative to organize this information for your primary care providers instead of just overwhelming them with everything that's not organized. That idea that you never get better, don't want to get better, of course, is not true, but you do need to acknowledge the chronic nature of your illness, help them understand that you understand that it's a chronic issue and you're not expecting them to fix you immediately, and then you want to show and communicate to them your hard efforts about what you're doing to do as well as you can. And the last one is, this provider's not knowing how to diagnose and treat CFS. That's just a learning process. You need to learn everything you can. And then, trying to give other people advice doesn't always work, but do your best to help give your providers good information so they know how to help you. Okay, well, that's the end of my slides, so I'm going to delegate back to Kim.
I'm trying to unmute myself there. Can you hear me, Cindy?
I can hear you. And
okay, great.
Yes, I can hear you.
Okay, great.
And I just clicked the slides back.
Okay, so let me fix that. And we've gotten, as you might guess, a lot of questions in while you were speaking. And Here we go. I'm just going to leave that up for now. But several people, when you first started out, and we're talking about the role of a specialist and how specialists are very focused and they're used to seeing certain kinds of patients in their practice, and they may not, I think you use the example of a cardiologist who's looking for valve problems and very typical type cardiac problems, may not pay as much attention to heart rate variability and orthostatic intolerance as you would like. And several people ask the question, how do they become educated about what specialists usually take care of so that they can better put their own symptoms into the context of the specialist's practice?
So I want to make sure I understand your question is, how do you pick these specialists?
Well, or how do you, before you go see a neurologist, how do you know what their expectation, what the neurology exam is going to consist of and which symptoms and problems to emphasize during that encounter?
Mm-hmm. Well, first you want to pick, just like picking a primary care that you can resonate with and talk to. If you can, try to pick somebody that is going to be more open-minded and less judgmental, but sometimes you really have no control over that with a specialist. I mean, if you don't resonate with your primary care provider, I'd get a new one. But you can't always choose that with a specialist. So one of the things I tell my patients is you actually have a mutual goal, and that is to be sure you don't have some other terrible problem, right? That really is the primary, is to make sure you don't have coronary disease, or you don't have valvular disease if you go to the cardiologist, or you don't have a cardiomyopathy. So, you can resonate with them on that, and you can say to them, I really first and foremost want your expertise to know that I don't have another problem. And then, I think that one of the problems is that many of the symptoms, and let's continue with the cardiology example, they're not considered dangerous once they fall in the realm of the CFS and fibro symptoms. They often aren't dangerous. They're just alarming. So if your chest pain comes from costochondritis or from painful chest wall or from an esophageal problem, you're going to feel like the doctor is dismissing you, right? But you need to put it in perspective and realize that their job is to be sure you don't have a severe cardiac problem. Now, if you can say to them, CFS is characterized by orthostatic intolerance, that might be helpful, but I find that they're not that good at treating it. So they don't want to. It's time-consuming. They don't want to spend a lot of time. They're not well informed about those issues. So either you can find a cardiologist that specializes in those issues, which might be difficult, or you go back to your primary care and say, look, the cardiologist thinks my heart is fine, but I want to talk to you about what I've read about orthostatic issues in CFS and see if you can help me.
Okay. What's your advice to people about bringing information printed off from the internet, journal articles? You had indicated in one of your slides that it should be concise and rather focused. What happens when the provider kind of looks at it, sticks it in the file, but doesn't pay it much mind? Should you try to move on to somebody else or work with that individual? What's the rule of thumb there if they aren't terribly receptive to information that's brought in by the patient?
I think you can assume that the majority of people are not going to hungrily take up what you bring. You can sort of start from that cynical viewpoint. So you want to maximize the chance that they will look at it later, and that is when it's from a high quality source and when it's simple and quick to read. And I think that doctors are taught to be skeptical. They're taught to be discriminating. If you bring them something from the New England Journal of Medicine or from something like that, they're probably more likely to look at it than if it's from somebody's blog, right? So you want to really be sure you bring them something that they will respect And there are plenty of resources through the CFS Association at the CDC website. There are lots of places you can get basic information about specifics, but whatever you do, just kind of have a thick skin and leave it and said, these are things that I've learned and I'd love your opinion about it next time I come, And then you just got to let them do what they're going to do, because you can't make them do anything. You can keep trying. And I tell people they should tame their primary care physician. They should train them up, because it's much easier to invest in the relationship and keep working on it than it is to find someone who's perfect. You're probably not going to find the perfect person. So if they're open-minded, they go back to those qualities, If they're relatively open-minded and relatively personable and accessible, then hold on to them and develop and cultivate your relationship over time. And then have reasonable expectations. Just remember that a primary care doctor has to take care of the whole gamut of medicine, right? They're not going to spend hours and hours reading about any specific illness, whatever it is they see. So you've got to kind of get in the queue and take their few minutes and hope that you can gradually educate them over time.
And somebody asked what to do if you know more about CFS than your doctor does, and I think that is probably likely to be the case unless they are seeing you or Nancy Klimas or Dan Peterson or one of the other few CFS specialists in the country. And I think that's kind of what you just addressed in terms of training them up and taming them, if you will. But it's unlikely, as you said, in a general medical practice that someone is going to have the level of expertise that we would hope.
I think that's a reasonable expectation. Your primary care doesn't have that level of expertise about any illness, to be honest, right? They don't have the level of expertise of a specialist. It just happens that in this particular area we don't have enough specialists to go around. Even if we had 100 specialists like me and the people you just named, they would never be able to see all the people in the United States, for example. Even if we had 100, they would never be able to manage seeing everybody who has this illness. It's good, and just like everything else, the bulk of things need to be managed in primary care. So really it's about cultivating a relationship where you can communicate and then gradually sharing that information. And again, you should be very selective about the information you share. Don't dump, hours of reading on someone. Try to bring that piece of information that you think relates to the issue at hand in little bites so they can kind of gradually learn over time.
Okay, what records, if you're seeing a physician or a healthcare professional for the first time, whether it's a specialist or a primary care provider, what records should the individual bring with them in terms of medical records, not more general information?
I can't speak for other physicians. I like to see results of tests and labs, copies of reports like MRI scans and labs and sleep studies. I don't care that much about everyone's opinions, right? I don't want to listen to everybody's lists of what they think is going on. I want to see data. So you want to let people know that you've had a workup to exclude brain tumor and those kind of things. So that's the kind of medical information I think is most important. I like to ask people all the specialists they've seen and what tests they've had for any of their conditions, because most of what we do in the diagnostic workup of CFS is exclusionary. Our job that's kind of intimidating is to make sure there's not something else going on contributing to the symptoms, and that's a kind of ongoing process.
And how about things like activity diaries that the patient would keep on their own? The chart that you showed where you had the red colors drawn in for the areas of pain, or things like that, something that would be helpful to a new doctor trying to establish a diagnosis or rule out other potential contributors to symptoms?
Yeah, I think it is. Those tools are designed to to convey a lot of information in a short amount of time, which is what's the problem, right, with a visit, is those doctors don't have time to have a long discussion with you and tease out all these different symptoms. So yes, if you could make a list of your symptoms, or in somehow, and especially somehow prioritize the symptoms about, how important, how much they impact you, or which ones are the worst ones, or what's the one that's most debilitating for you right now, or which one's frightening you, what's the one that's making you worry, there's something else going on, so that they can focus. But any brief, simple, kind of concrete tool you can bring in to convey information, I think will be helpful. Now, I'm going to acknowledge, frankly, that sometimes people just don't want to hear it because they know it's going to open a Pandora's box, right? When you ask a question about a complicated thing, they know they're going to have to take more time. But if you want them to help you, you're going to have to convey that information in some way.
What is the best way for a patient to start a dialogue about the medication sensitivities that are so common in CFS, and the fact that medications often have to be started at a very low dose and gradually increased?
I think it's best to just say that, and say, I'm willing to give this a good try, and I will follow your instructions, but I would ask that you allow me to start low and work the dose up, because I tend to be sensitive to medications. And I know sometimes people won't listen to you, but ask for a tablet, talk to the pharmacist about getting the type of a dose that can. I think you're just going to have to try to communicate it. There's a big range in my clinic of how well people tolerate medications, and sometimes hard to predict. So in someone who's going to need more of a medication, it's a long journey from starting with a small dose to get up there. So I can understand why clinicians sometimes want to go with the dose they think will work. So really it's just openly, what they want to hear is that you're going to stick to this medicine. So you just need to say, look, I'm going to give this my best try, but I need to start low.
Okay. A couple people asked about the sort of tension around, do I rest up for several days before my doctor's appointment so that I'm in the best shape possible, but then they potentially don't understand how severely ill I am? Or do I kind of let it all hang out during my doctor's appointment so that they understand the impact that the illness is having? And somebody also commented that one of their doctors was so impressed with the careful note-taking and organization she had done before her visit that he dismissed the cognitive complaints that she had, saying, well, if you could put all this together, you must not really be having those problems.
Mm-hmm. Yeah, I don't know. I mean, I think all of them are important. In my office, I definitely want people rested when they get here so they don't have so much payback from the visit, and we can have a more productive visit. But it would be good to, it strikes me when my patient says, we came yesterday so that we could get a good night's sleep and I could come and be rested for your appointment today, and we're going to stay in a hotel tonight, for example. I mean, they communicate to manage, and that helps me understand a little bit about their level of focus. Saying to the doctor, I want you to know that here's what I did to prepare for the visit today, and here's what's going to be the consequence of coming. I don't know. I mean, I don't know how to open the ears of people that are non-believers, except kind of putting on a thick skin and kind of neutrally conveying information to them. If you end up at the appointment very ill, just simply say, I'm sorry, I'm very ill today because, I had this and this and this yesterday, but I wanted to make it to my appointment, but, this is how I get when I've done too much. So either one can be a demonstration to your clinician about, what happens with you. That issue about keeping notes and cognition and stuff, I know it's difficult because some people can say, you know that you're a perfectionist or you've got OCD, and sometimes if you keep good records. I like records myself, and I can see through that, but keep your records simple and don't be pushy with them. Just say, I hope this might be helpful for you. I know it's hard to communicate these issues. I wanted to get it down for you. And you can also tell people that it took the time it took you to prepare those things. So patient will say to me, you know, I filled out these forms. I had to do it over several days, but I wanted to get them done, and it was a challenge for me and wore me out, but here it is.
Several people have asked, if I have good specialists, do I need a primary care doctor? I think you've answered that, but it might be worth repeating.
You know, I don't know how to answer that. I have a bias because I'm a primary care doctor, and I really feel that having a primary care doctor is a good thing if you can find the right person. If your specialists are capable of covering everything and they communicate together, and you're sure that nothing gets missed, you know, you'll have to use that judgment. If they're doing that, they're stepping outside their specialty role and sort of becoming your primary care physician. So you'll have to take it on a case-by-case basis. But the biggest thing that happens is certain things get neglected. There's a big missing piece.
Talking about medication issues, what's the best way to start a dialogue about access to free or reduced cost drug programs with your physician? Is that
I think that it sort of depends on if your physician is part of a big healthcare plan, so that there's kind of one set of rules they need to learn. But most providers kind of have to deal with a lot of different plans and a lot of different ways of kind of working the system, so it becomes a little bit overwhelming. I think of that as being the role of the individual. Get on the internet, put things in Google, go to the site of the pharmaceutical company, do the research on your own, get someone to help you. But I think asking your doctor to do those things might be an additional burden to them, and they really might not have the answers, and it just starts to make them feel overwhelmed again.
Are there things that are common in CFS fibromyalgia patients in dealing with potential surgical procedures that may need to occur as a result of specialist visits that they should go in knowledgeable about on the front end? Anesthesia, recovery times, extra hospitalization.
Yeah, it's pretty common sense, actually, and what I usually say to people is, if you have to have surgery, you have to have surgery, right? If you got a bad gallbladder or you need back surgery, whether or not you have CFS should not be the determining factor at all about whether you're going to have the surgery. So at least you know if you're going to do it, you got to do it. So mostly it's a matter of letting them know that you might need more recovery time, or you might have more pain. They need to understand the medications you're on so that they can appropriately adapt the new medications that will be used during the admission. I do a few more things than that. I usually tell the one other thing I do besides allowing more recovery time is I encourage the patients to have them get plenty of IV fluids surrounding their surgery, because for people with orthostatic intolerance, it's very helpful to have adequate IV fluids before, during, and after their surgery. But otherwise, just letting them know that you might have more pain or take more recovery time. You just have to do it. I don't think people do that much worse than anyone else, other than needing a little more time to recover.
And that may or may not be in a hospital setting.
Right. You just may need to allow yourself more time, once you get home. And if you have pain issues, you need to have a good relationship with whoever in advance, with whoever's going to be managing pain medications, because that is an important stressor. I've seen severe post-operative pain that was, very poorly controlled become the cause of a relapse in some patients. So before you go into it, know who's going to be prescribing those pain medications, and that you know how to reach them.
Oh, I'm scanning through questions here. A couple people have asked about what terms to use in talking with their healthcare professionals about these conditions, whether to stick with CFS, fibromyalgia, or to use the myalgic encephalomyelitis. What terms are doctors more likely to be familiar with and to put more confidence and validation in at this point in time?
I just lost you for a few minutes, so I did not hear that question, but you're back now, so could you repeat it? I lost the audio for some reason on your side.
Okay. I don't think the question was, what terms in describing these conditions will carry the most weight and validation with healthcare professionals right now at this point in time? Chronic fatigue syndrome, fibromyalgia, myalgic encephalomyelitis, ME/CFS. What terms do you think they'll be most familiar with and most likely to consider valid?
I think there may be regional differences in terms of what terms are more commonly used because of approval of drugs for fibromyalgia syndrome. There's definitely been a huge increase in awareness about what fibromyalgia syndrome is, at least about how we define it, and some of the treatment options. In some ways, it's sort of pushed CFS back into the shadows a little bit. I don't know how to answer that. I think you can try to talk to your providers and ask them. And I don't know. I think some places accept one thing more than another. Definitely ME is more problematic for most people in the country.
Just because it's not widely used here in the United States, yeah.
Right. Although I do think that exposing physicians to the term can be helpful. It sort of piques their interest, right? It's that important sounding name that it's always sounded like a better label. So if you have a good relationship with them, introducing them to the idea of ME is not a bad idea.
What do you find that traditional medical doctors, physicians, sort of the current viewpoint on alternative medicines, supplements, things you find in the health food store? Obviously, you had indicated that you should include everything you're taking on your list of medications. Is that likely to be kind of a red flag that for your physician? How should people handle that?
I think that varies tremendously also. I'm of the belief that you should provide that information because those are medicines. I look at herbs and supplements as being medicines that are maybe a little less refined or a little less well understood, that have actions. And my only criticism about alternative sources is when they say that there are no side effects, right? Or they can never have an adverse effect, which just isn't true. So it can be a red flag to someone who is opposed to use of those things. So I think on an individual basis, you're going to have to kind of work that out with your providers.
Okay. And we've talked some about medications. What about diagnostic testing that somebody might want to have done as a result of things they've seen in the literature or kind of evolving understanding of things like immune system regulation or orthostatic intolerance? If a physician doesn't bring this up on their own, how's the best way to lead into a discussion about tilt table tests or NK cell function tests or MRIs, things like that?
Okay. First priority is any studies that help rule out other problems or when we practice medicine, we make decisions about studies based on how they're going to change our decision making. So if someone has sciatica, I decide about an MRI based on the severity of their physical exam findings and whether it's going to change what I do, right? Is it going to prompt me to send someone to a specialist, etc.? So just because you want something and the information would be interesting, it doesn't necessarily mean that it's going to get done, whether it's mainstream medicine or whether it's a little bit more peripheral. So when it comes to tests that are specific to chronic fatigue syndrome, you're going to meet more resistance. So the real question is it going to be pivotal to some kind of decision making? Is it going to change your treatment? Is it going to provide and open some door that otherwise wouldn't be there? So that tends to narrow it down. I mean, a lot of tests we would like to get for CFS are really research tests. So if you can talk your doctor into it and have a discussion with them, but it isn't necessarily imperative, right, to your care. Let me give you a concrete example. I cannot get people to do a tilt table test here in Utah anymore. I believe in it. I've done a lot of them, and they've stopped doing it because it's not very lucrative. It's time consuming, and the university stopped doing it, and I can't get anybody else to do it. So I've just had to readjust, and I make a clinical decision, and I use people's symptoms and the measurements I can do in the office to make a decision about whether I'm going to treat orthostatic intolerance, and I skip the tilt table test. It's unfortunate, but that's kind of the state of accessibility of testing right now, and many, many things we'd like to have done in CFS are not going to get paid for, or they're less accessible, or the labs that do them are not reputable. So I think you should try to decide on your own and maybe with your provider about whether it's really going to make a difference for you, if it's worth money to send it to a specialty lab or whatever, and if it's going to be pivotal to decision making.
Okay. We often think about getting referrals from our primary care provider for specialists, but does it ever go the other direction where you have a specialist who could refer you to a primary care provider, since that's such a central part of the overall health care?
Yeah, that's a good question. One of the good things about referrals is doctors know each other. They refer back and forth to each other. They know who might be more open to this diagnosis, or they know who might be better at it. So if you have a specialist you're working with that kind of gets it and likes it, but they don't want to manage your whole syndrome, they probably have a great idea of who they might resonate with, and who could provide good care for you as a primary care provider.
Let's see. We're actually getting through quite a lot of these, and we've had some questions there of a more personal kind of, I have this symptom and I need to take this medicine, or I'm on this dose, and we just can't get to those types of questions today. So if you've typed one of those in, sorry, we won't try to address that this afternoon. I put back up on the screen your slide about kind of realistic expectations, and a few people have asked, what should I expect? What is reasonable? And I went back to one of your slides. I hope you can see it on up there, Cindy.
I can. I was worried when it flipped up there. I thought, oh, my computer's going crazy.
No, if you could maybe just recover those points. I think they bear repeating, since that's sort of the take-home message about realistic expectations and then working toward achieving those in a partnering fashion.
Mm-hmm. Yeah, I mean, I think these would be my goals. Sometimes when patients come to me, their symptom burden is very high. They're going up and down and crashing, and they're doing too much, and they don't know how to pace. So my goals really are to reduce the symptom burden. You're never going to get rid of all those symptoms. That's the other thing I tell primary care providers is, this is a chronic illness, and these are the features of the illness that are never going to go away. That doesn't mean they can't be improved. For example, sleep disturbance. I mean, I just think it's kind of lifelong that people are going to have some problem managing their sleep. And another one might be activity intolerance in someone with CFS. That threshold at which relapse occurs might get higher and higher or better and better. But I still have people who relapse who've been quite healthy because they just, did too much. And so reducing symptoms is important, and stabilizing the course. And most people with CFS do that on their own. When I meet someone in the first few years of illness, they're much less insightful about managing as people who've been sick for 3, 4, 5, 10 years. They've learned by trial and error how to stabilize their course and come to some kind of peace with the things you can change and the things you can't change. And then maximizing function is really about finding ways to do the things that are reasonable and possible. An example might be, if we can't get strength and fatigue better, then we suggest using a wheelchair for long distances or going shopping or going on vacation. There are ways that we can find tricks and things you might not have thought of to help you go out and live your life. So, I'd like to say that, everybody wants to be cured, but think about your illness. Think how long you've been sick. Think about all the specialists and how, we continue to follow large numbers of patients. We know how to advocate. We know how to reduce symptoms. We can stabilize the course and maximize function. But I love it when people get better, and sometimes we hit on things or people, tend toward better. But I don't see it as my role to fix people or cure them. So we all need to have reasonable expectations. And then, whatever happens is great on top of that. I usually try to help people have reasonable expectations, and then if things go better than that or we make better improvement at that, it's all frosting on the cake.
One last question, and then I think we'll wrap up. CFS and fibromyalgia both have many symptoms, and things can move around the body and be more or less problematic over time. How do you, as a physician, work through it with your patients when something new happens? How do you decide whether that's just a new element of CFS or whether that might be a different health problem occurring as a consequence of long-term illness or aging or just some of the more common things that occur over the lifespan?
That's really the main reason to have a primary care provider, right, that knows you over time, because they become familiar with what's happening day to day and what the ebb and flow of your chronic illness might be. So I feel confident when someone comes in and they've got a new glaring symptom or something that we haven't experienced or we can't explain why things are worse. That prompts me to step outside the CFS paradigm and readdress another diagnostic workup to see if we can find some of the problem going on. Often people will come in and I have them do those symptom scales, and I'll try to see on there what's worse, or I'll say, how are you doing? Is there anything new? And then I'll backtrack with what's happened in the last period since I saw them to see if I can explain it. Like their pain is worse or their sleep is worse, and I talk about what they've been doing and if they've changed their medicines and if some new stressors have come into their life. If I can explain with some satisfaction why it's happened, and if we can come up with a reasonable explanation, then we'll kind of watch it. But if it comes out of the blue or it's severe, definitely warrants new workup. It's one of the reasons I try to partner with a primary care physician as a specialist, because I can get kind of lulled by it, and I want two of us to be looking at the patient so that if something new comes on, one of us will have a little bit of a fresh view, and maybe if two of us are watching, we won't miss it. But with such a high symptom burden, so much chronic illness, you just have to be have some kind of a system to pick up new things. There will be new problems with aging. There will be new problems. You might get hypothyroid or develop some kind of sleep apnea or whatever. So you do have to have that balance back and forth.
Okay, great. Well, Cindy, this has been tremendous, and we've gotten a lot of positive feedback about how helpful and practical, also a bit overwhelming to folks to think of all the things that they need to keep track of on their own. I think healthcare delivery is changing somewhat, and it's more important than ever that each individual is their own best advocate in the healthcare system. And that's probably not likely to change for a good while. Couple things that if you could send me, and I'll share with the folks who've participated today, if you have a blank, one of those human drawings that you used with the red crayon, so that we can make that available as part of the slide deck for folks if they want to use that on their own and keep track of their pain with that simple diagram. We've had several requests for that. And we will include in the follow-up email that we send out links to a couple of concise overview articles that may be helpful in terms of communicating with a healthcare professional about the common features of CFS. It won't turn them into an expert, but for introductory purposes, we do have a couple of resources, as Dr. Bateman mentioned. And just some reminders about our last two webinar programs of the year. Next week on Thursday at 1 o'clock Eastern Time, we'll have with us Dr. Bruce Campbell and Dr. Dane Cook to talk about minimizing relapses, pacing yourself through the holidays. And as Cindy mentioned earlier, pacing is one of the key strategies to balancing activity and rest and trying to achieve some level of predictability of effort over time, and especially through the holidays when there are more demands on most people than at other times of the year. We thought this would be a really timely program, and then Dr. Campbell will talk about those issues, and Dr. Cook will give his perspective on the science end of things, of why this is going on in the body. He's an exercise physiologist and understands sort of the mechanics of post-exertional relapse, which may help you gain a better insight into why this occurs in CFS, a rather unique feature of the illness, and for many people the most distressing one of all. And then on December 2nd, we have Dr. Gail Ironson from University of Miami talking about spirituality and health, another sort of seasonal topic that we has been requested many times over the years. So we'll address that and then take a break and launch a 2011 series early in the new year. As I said, we'll follow up with an email with links to the recording of today's program and also the slides. We house them on our website as well as our YouTube site, and you can find past recordings of the other 16 programs there already. Also, just to make sure that everybody's got our URL for our main website and Facebook page, I also included a link to Offer, and Offer's just put up some videos from its most recent conference that was held in, that was September, wasn't it, Cindy?
September 11th.
Yep, September 11th, with Dr. Ela Singh and colleague Dr. Suzanne Vernon, our scientific director. So take a look at the materials available on Offer's website for yourself, as well as communicating with your healthcare professional. And then just a reminder, we do reach new people all the time through our webinar series. This is the CFS Association of America's mission, strategy, and our core values. And if this webinar series and other things that we provide in terms of communication, our research program, our public policy work is important to you, we encourage you to support the organization. It's the fourth quarter and end of year, and people are making decisions about charitable gifts, and we would be grateful for your support to continue providing this type of programming and the critical support of research and policy engagement that the association sort of uniquely provides. And with that, I think we'll wrap up. And Cindy, thanks once again. You are our most frequent alumni speaking of your third webinar here, and hopefully everything went smoothly today. We didn't lose you, and maybe the recording took. And we won't suffer some of the same problems we did on the first 2 times through. But grateful for your many contributions and for sharing such important information with us today. And
happy to do it.
Thanks to everybody who hung in there. This has been a great way to reach people, but I know even though you don't have to travel anywhere, it still is requires a lot of attention and energy to take part in this. So thanks to everybody who participated today, and wish you a pleasant afternoon and a good rest of the week. And again, thank you to all our serving veterans on this Veterans Day. Take care. Bye-bye.